Welcome to our monthly webinar series hosted by the Eugene S. Farley Jr. Health Policy Center and the Department of Family Medicine at the University of Colorado School of Medicine. Let me begin by telling you a bit about our sponsor and partners. This webinar series is sponsored by the California Mental Health Services Authority Integrated Behavioral Health Project. CalMESA is an organization of county governments working to improve mental health outcomes for individuals, families, and communities. Prevention and early intervention programs implemented by CalMESA are funded by counties through the voter-approved Proposition 63, the Mental Health Services Act. The Agency for Healthcare Research and Quality Academy for Integrating Behavioral Health and Primary Care functions as a coordinating center and national resource for people committed to delivering comprehensive integrated healthcare. The Academy focuses on integrating behavioral health into primary care practices and promotes a collaborative environment that fosters dialogue among leaders and other stakeholders. Key Academy tasks include the National Integration Academy Council, an expert panel of nationally recognized leaders in integrated healthcare, the Academy web portal and literature repository, and the recently developed lexicon for behavioral health and primary care integration. The Collaborative Family Healthcare Association is a nonprofit, member-driven collaborative organization in existence since 1995. CFHA promotes a comprehensive and cost-effective model of healthcare delivery that integrates mind and body, individuals and families, patients, providers, and communities. The Advancing Care Together, a project at UC Denver Department of Family Medicine, is a 4-year program aimed to discover practical models to integrate mental health, substance use, and primary care services. The program is funded by the Colorado Health Foundation, which funds 11 demonstration projects that have been organized as a set of diverse comparative case studies that will be linked to support cross-project learning. Before I introduce Dr. Brown-Levy today, I'd like to go over a few housekeeping items for GoToWebinar. On the right-hand side of your screen is the GoToWebinar control panel, where you can listen to the audio through your telephone or computer's microphone and speaker. And on the left-hand side is where the PowerPoint presentation will appear in the GoToWebinar viewer. At the end of the presentation, we'll have 10 or 15 minutes for questions, so please submit your questions using the chat box underneath at the bottom of your GoToWebinar control panel, or you can raise your little hand icon and I can unmute you and you can ask the question verbally. The webinar is being recorded and will be posted on our YouTube channel, which is displayed on the screen now. Dr. Chandra Brown-Levy is a licensed clinical psychologist and the Director of Behavioral Health Integration at A.F. Williams Family Medicine Center and a Clinical Health Policy Research and Evaluation Associate at the Eugene S. Farley Jr. Health Policy Center, both within the Department of Family Medicine at the University of Colorado School of Medicine. Through her work, she strives to advance the field of behavioral health and primary care integration with regards to clinical, operational, educational, policy, and financial perspectives. Today, she will present on working with patients with borderline personality disorder in primary care. Welcome, Dr. Brown-Levy.
Okay, well, thank you for having me today. I'm going to be speaking with you about working with patients with borderline personality disorder in primary care. This is a topic that comes up frequently in our own clinic, and so I hope that some of the information we discuss today will be helpful to you all. So some of the things that we're hoping to cover today is understanding the prevalence and related statistics of borderline personality disorder, being able to recognize the criteria and conceptualization for borderline personality disorder, and understanding and being able to apply skills related to this disorder. So a lot of times when people see this disorder on a chart or even hear that a patient has it, the first reaction is kind of no thanks. Some might go running in the other direction, but hopefully through the discussion we'll have today, you won't have to feel that way. There are things you can do to help you increase your own feelings of competence. So I hope that this webinar will be helpful to you. So a little bit of self-reflection, just some things to think about. What have your experiences been like when you've worked with patients with borderline personality disorder in the past. So what might some words be that would come to mind? I put a few on the screen here because these are the words that tend to come up initially, kind of the first things that tend to come to people's minds. So things like that it's going to be a difficult situation, that these patients are frequently suicidal, it could be very overwhelming, draining, or that you'd have to look out for splitting behaviors. So these are some of the things that could be the first words that you might think of. Hopefully, again, today you might be able to feel like there are some other words that will also come to mind. So in primary care, this is a disorder that tends to elicit very strong feelings in physicians. It can lead to the development of some problematic interactions and relationships, and can complicate the task of diagnosing and managing a variety of different disorders. Unfortunately, it often negatively affects the course of all sorts of conditions, medical conditions, and adds a lot of complexity. There can be a lot more frequent office calls, visits, prescriptions, and higher utilization. You may see this both in the primary care office as well as with specialists, maybe even ED and inpatient stays. So what are some of the things that make this so challenging? Well, the chronicity, the pervasiveness, and some of the inflexibility of the associated symptoms are some of the things that make this challenging. Getting patients the care they need can also be extremely difficult due to patient preferences and limited access to trained providers. So a lot of people who work in integrated care or not will know that sometimes getting those referrals can be really challenging, and this is just another layer of complexity on top of that. So access can be really, really difficult. And a lot of times you're going to see more people in primary care really than anywhere else. So it's important for us to have a good understanding in primary care. Here are a few numbers to think about. According to DSM-5, the median population prevalence is estimated between 1.6 and 5.9%. In primary care, it's about 6%. Outpatient mental health clinics, you would see about 10%. Psychiatric inpatient prevalence is about 20%. Unfortunately, this is an often fatal disorder, and so up to 10% of patients end up completing suicide. Sometimes there are perisuicidal behaviors before that, and unfortunately, sometimes those behaviors can lead people to feel like they don't need to take them as seriously over time, but because there is a high rate of completion as well, it's always important to take it very seriously. Also, there is an under-identification in primary care, and in one study, 42.9% of borderline patients were recognized as even having an ongoing mental health problem. So that's part of the reason why we see these changes in the ranges of statistics. Also in one study, 21.4% of patients with borderline personality disorder were experiencing suicidal ideation during their last primary care visit. So you figure this is a little over 1 in 5. So it's always important to ask about. Also, about 75% of those diagnosed are female. A little bit more about DSM-5, just to give you a sense of this disorder. You can also look in DSM-5, is that this is a pervasive pattern of instability of interpersonal relationships, self-image, and affects, and marked impulsivity beginning by early adulthood. And it presents in a variety of contexts. And you need to have 5 or more of the following to actually be diagnosed. So frantic efforts to avoid real or imagined abandonment, pattern of unstable, intense interpersonal relationships. This is the alternating between extremes of idealization and devaluation, this kind of I hate you, I love you, black and white. The identity disturbance, it's marked and persistent and unstable self-image or sense of self is what this is referring to. Impulsivity in at least 2 areas that are potentially self-damaging. So there are a variety of different behaviors you might see here. It could be, of course, more than 2. Recurrent suicidal behaviors, gestures, threats, or self-mutilating behavior. Affective instability and reactivity of mood. So this is where you can see lots of mood changes within a day. So this is different, although a lot of times there's a little confusion here with bipolar disorder. So you would see lots of changes within a day as opposed to having a period of several days of elevated or depressed mood. That's part of the difference between these two. They are pretty distinct disorders, although a lot of times they do get confused. There's also chronic feelings of emptiness, like there's kind of this bottomless pit you can't kind of fill up. Also inappropriate intense anger, difficulty controlling anger that could be displayed in a number of ways, and transient self-related paranoid, stress-related paranoid ideation, or even some dissociative symptoms. There are some high-risk concerns that make sense to pay attention to, including so antisocial and borderline personality disorder. Sometimes you see a lot of overlap in those two, and so these are the two most prevalent personality disorders among substance-using patients, with reported estimates of 22% for antisocial personality disorder and 18% for borderline. Also, for patients with borderline and antisocial, they're more likely to participate in sexual and needle-sharing high-risk behaviors. In terms of development and course, there is considerable variability here. There is the most common pattern is chronic instability that you'd see that would manifest by early adulthood. There's impairment and risk of suicide that tends to be greatest in the young adult population, and it gradually lessens over time. For those who are engaged in therapeutic interventions, they tend to show improvement in the first year. This is if we can get them actively engaged in those interventions that they need. And then once patients get into their 30s and 40s, a lot of times you see more stability coming in. Another interesting component is that after about 10 years, about half of those, I'm sorry, this is an older slide, I needed a little updating, about half of those identified as meeting the criteria no longer have a pattern that meets full criteria. This does tend to be a cyclic problem. So for patients who carry this diagnosis, it is difficult for them to have good relationships because they can't regulate their emotions. And without good relationships, it's difficult to regulate emotions, and you're that much more emotionally vulnerable. So it's kind of this cyclic pattern. MARSHA Linehan is the expert in borderline personality disorder, and so I'll be sharing a lot of information with you that comes from her and her research. But individuals with this disorder, there's this idea that they're born with an innate biological tendency to react more intensely to lower levels of stress, and then they take longer to recover. So it's almost like the idea of not having an emotional skin or protective barrier that would allow you to be able to regulate those stress levels a little bit easier. So they tend to peak higher emotionally with less provocation, and then it takes them longer to come down. So what can you do? In terms of conceptualization, this comes directly from MARSHA Linehan, and I'll read this quote. So one wants to conceptualize the behavior in a way that will keep you liking the patient. So if given the choice of two different ways of thinking about what someone does, you ought to think about it in a way that keeps you liking them, because if you don't like them, it's incredibly hard to treat them. And I've never really liked a person that I thought was manipulating me. So this is just a little bit of a way to reconceptualize how you might even approach this patient, potentially before you even meet them or while you're in the course of treatment. Other things you can do, so a lot of times the term manipulation gets thrown around. It might be one of those first words that came to mind. And a lot of times we think about this as potentially being a pretty unhelpful and maybe even a misleading word to use. So if you think about the word manipulative, a lot of people are manipulative, but sometimes they're manipulating you in a way that you don't even realize it because they're so skillful and artful in handling a situation. This is pretty inconsistent with a lot of the behaviors that we see that are part of this disorder. And actually patients could benefit from being more skillful and artful. So a little bit of a spin on the term manipulation here. So what are some primary care skills that might be beneficial? Alliance building is huge. Trying to build that alliance and let patients know that you care about them and you want to help them. Educating patients about their symptoms could also be very beneficial, letting them know that these things actually do tend to fit together in a package that makes sense and we conceptualize in a certain way. And even putting a name to it might sound intimidating, but could be very beneficial for the patient and might even enhance your relationship if done skillfully. Referrals may be beneficial as well. And then within that, encouraging communication and cooperation from the healthcare team. So if you're lucky enough to work in an integrated practice, this could potentially be done within your practice, or it could be done with providers in the community. So you might want to utilize your community and look to see who are the people that can help this patient, get them activated and connected with treatment and resources that would be beneficial. Another thing is foreseeing and preventing morbidity when at all possible. It's good to know that with successful management, you can feel a lot better about your practice, and informed doctors and providers of all sorts can help, with the help of a multidisciplinary team, can make really valuable contributions to help these patients. Can also avoid misunderstandings, frustrations, and exhaustion. So basically the whole team benefits, providers, patients, and hopefully they're getting healthier and you're feeling better about the care that you're able to provide. So in terms of communication skills, listening, of course, is huge for everybody, and trying to elicit a full agenda if you can. Even if you can't get to every item, if there's a way you can use your team to try to at least help the patient feel that they're being heard, very, very important and helpful. Appropriate eye contact is huge, so letting them know that you're listening to them and you're paying attention, using body language that's conveying that respect, avoiding abrupt movements that could be startling. These are kind of basic skills that are pretty beneficial regardless. Potentially, trying as best you can, even though it can be very, very busy in a primary care setting, to communicate in an unhurried manner, or at least set up an agenda so you can address one item thoroughly. Avoiding the use of humor that might signify disrespect, unless, of course, you can do that because you have established appropriate rapport and that it is beneficial in some way. But you want to always be professional and make that person feel respected. Offering choices and options is also really beneficial whenever possible, and involving patients, sharing the responsibilities of care. Again, just good clinical skills that are appropriate across the board. Structure is huge. Actively structuring the interview, the visit. The greater the organization, the greater the level of security experienced by the patient. Responding to repeated messages by expressing commitment to the relationship within those negotiated boundaries. And sometimes even having that in writing can be very beneficial. Scheduling brief and frequent visits, and keeping that in line with goals to be addressed, can keep a patient from feeling like they aren't being heard, or maybe feeling like they need to go elsewhere to get their needs met, potentially an ED or something like that. So developing a treatment plan with goals focused on health and behavior, specifying unacceptable behaviors and consequences if needed. And when patients know that their providers want to see them regularly, it can cut down on some of those challenging behaviors. So things like, I really want to see you, I really want to help you get better and feel better, and I want to make sure that maybe we visit with each other, every 2 weeks for a little while until we get this under control. Maybe even weekly if that's what's needed. Remaining calm and empathetic can help diffuse hostility. You might notice that patients who carry this diagnosis could become angry at times when you don't even expect it. So it could be startling or surprising. You can respond to that by recognizing the feeling when also requesting an appropriate behavior. I could understand how you might be angry about this, and I would like to speak to you about it if you could lower your voice, something like that. If the patient doesn't respond, you could voice awareness again of that heightened emotion and maybe suggest that a break be taken, or that maybe even the appointment be rescheduled at another time. But maybe even just taking a few minutes of a break, stepping out of the room, and then coming back in if that's appropriate and safe to do so. Beware of splitting behaviors. So this relates to the inability to integrate the good and the bad images of people. And so you want to make sure that your team is on the same page. Be aware that agreeing with a devalued view of another treater could be a form of splitting, or being overly protective of another person could be another form of splitting. So you just want to address that really thoughtfully, and a lot of times neutral language can be helpful here. Counter-transference can be seen in a number of different ways. So this is the idealization, devaluation that's often part of the patient's the provider's emotional response to the patient. There's positive and negative countertransference. The provider responds to the idealization in a manner so as to continue accolades they might be getting from the patient. So you want to be aware if you're giving in to special requests that maybe you wouldn't do otherwise, or that maybe wouldn't be medically warranted, or the opposite, ignoring, avoiding, or devaluing complaints. Again, not the same way that you would with other patients. So checking in with yourself to see, is any of this happening, and how is this impacting care? And this could be a place where supervision or consultation with someone else would be beneficial if you're not quite sure if this is happening. Open and honest discussions, always great, especially related to the role of emotions and medical concerns. If you've done a thorough H&P and there's no abnormalities or explanations for the symptoms, a thoughtful discussion about the relationship between life stressors and health can be really helpful. So medically unexplained symptoms can be part of this, especially with chronic rotating physical complaints. Attempting to focus on the specific complaint with a brief discussion of their concerns. And chronic pain is also something that might be a manifestation of the self-regulatory disturbance. So you might see a lot of crossover between patients with chronic pain and then also borderline personality disorder. So you might, like we said before, consider reviewing DSM criteria with a patient so they can see that this is actually part of a condition that is recognized. Helping the patient feel more understood could also help them accept treatment in general and say this is something that we know is happening and there is treatment available, and there's good research to show that a lot of people do get better with this treatment. Educating support staff about how to engage with patients. So making sure that the whole team knows how to engage in the most appropriate way to keep people feeling safe all around. Clarifying roles and responsibilities as well for the team, including the patient, and involving staff in the treatment planning can be helpful, especially with some of those frequent phone calls and messages. So partnering up for physical exams and overall treatment is a good idea. Sometimes there are significant boundary difficulties, and so there could be misinterpretations associated with a regular medical exam, believing that this is indicative of a personal relationship rather than a professional one. Medical providers may insist on the patient participating in psychiatric care to establish an effective working relationship. So especially for PCPs, they may say, we really need to engage a psychiatrist, behavioral health provider in the treatment plan. And it's also advisable for PCPs treating patients to have a psychiatric colleague available for collaboration and consultation. They're treating for patients, they're treating physicians. They could benefit greatly from a collaborative model to try to prevent some of the unintended consequences of systemic issues that could potentially play into some of the symptomatology that you would be hoping to reduce. And so multidisciplinary care teams and care planning is recommended. You'll know that suicide and self-harm are likely to be issues, and so you want to acknowledge that and kind of be prepared for it right from the onset. Know that these are types of behaviors that tend to reduce guilty feelings, and a lot of times the intent is not death. However, due to impulse control difficulties, sometimes there is inadvertent death, even when a patient is not intending suicide. So you always want to take those behaviors very seriously, document consistently, and know that these are unhealthy ways that these patients are dealing with their disorder. So if you are too uncomfortable with this, you may decide that you are not the best provider, and you might want to refer the patient to another provider who may feel more comfortable managing these symptoms on a regular basis. DBT is a treatment developed by MARSHA, LINEHAN, and there are great programs that have good outcomes showing that this is beneficial. There are 4 stages through this program. And so what I'll do for the remainder of the webinar is talk to you about how you can pull some of the pieces from this into primary care and use some of these skills with patients in primary care. So I was trained in a DBT program, and so was able to modify some of these skills in our own practice. So if you have somebody on site who has that training, it's always great to utilize that resource. Otherwise, there are great books and workbooks that you could read, buy, or go to workshops to shore up on these skills. So there's a lot of reasons why you might want to incorporate these skills. I would say they're just good life skills overall. So they can be very helpful for patients with borderline personality disorder. They can be good for your own practice with a wide variety of patients, help increase your feelings of competence, increase your ability to work with a variety of difficult patients, work in a way that keeps you feeling good about what you're doing, feeling more competent, confident, and improve, potentially maybe even your own interpersonal effectiveness, emotional regulation, and distress tolerance. Like I said, they're just good life skills. So some of the skills include mindfulness, interpersonal effectiveness, emotional regulation, and distress tolerance. Those are the 4 modules of DBT. So what is Wise Mind? This is one of the mindfulness-based skills. And so I'll talk a little bit about this. So basically, it's the idea that we have these 3 states of mind. We have the emotional mind, or the hot side. This is the side that's, responsible for, your feelings and connecting with people on an emotional level. It's good for lots of good things. None of these things are bad. It's just recognizing when you're in one or the other and trying to integrate them in a way that's going to be most beneficial. And then reasonable mind, this is kind of your rational, logical mind, helps you evaluate, plan. It's kind of the cool side. And then the wise mind is the integration of those 2. So usually the example I use is if anybody is familiar with little kids, a lot of times, fall down and maybe they scrape their knee, something like that. And of course, you need to attend to them, make sure that they're okay. Maybe they need, a little Band-Aid, Neosporin, wash it off, make sure it's clean. And the fact that you're able to think through that and do that, that's your reasonable side. You can recognize a situation and attend to it. Well, with little kids, a lot of times you also need to attend to the emotional side, which is kissing the boo-boo. It's all better. So the reasonable side is the one that's washing it off with soap, maybe some Neosporin, maybe a Band-Aid, walking through those steps to making sure that they're okay, making sure that there's no bone sticking out, that sort of thing. And then the emotional side is kissing the boo-boo and making it better. Well, both of those things are necessary for your child to feel better. And if you do one without the other, you're kind of missing a piece of the puzzle. So that's where Wise Mind comes into play. You're able to integrate both of those and do them both. And then hopefully you have a happy little kid who's back to play. So how could you use this with a patient? So maybe a patient comes in and they could say something like, I'm having a hard time controlling my anger, keeps getting me into trouble, I'm so upset I can't even think straight, I'm worried if this keeps happening, I'm going to lose friends, my job, maybe their job is on the line. Maybe they're not saying this quite so succinctly, but you're getting the sense that these things are happening. So you could even say, wow, that sounds really hard. You're validating the emotion, but you're not alone. There's other patients who I've worked with who've said very similar things, and I've talked to them about this theory that we have 3 different ways of thinking through situations. And then you can present this skill and see how that works for them. And maybe they can even come up with an example of how they could start using Wise Mind. So distress tolerance is another skill. So breathing is a skill that we use a lot in our clinic for all sorts of different things. And observing the breath is one of the distress tolerance skills that we can pull in pretty quickly and easily. So there's lots of, through the DBT manual, you can pull out lovely worksheets that will help walk through this process. And so there's deep breathing, so you can teach diaphragmatic breathing. That's part of this. Measuring your breath by your footsteps, counting your breath to 10, following your breath while carrying on a conversation, going for a walk, and just letting the person you're working with guide which of these seems like it would be most beneficial to them. This is a great distress tolerance skill. It doesn't cost anything, and we're breathing anyways. So I usually say that, you might as well do it in a way that's going to help you feel better. Also, there's distress tolerance that's related to distracting with the acronym ACCEPTS. And so we say if you're going to distract, sometimes you need a little distraction, just that little break, and then you can come back to whatever it is that you need to deal with. So about a 24-hour break, probably at the most, before coming back and dealing with the issue. There's lots of different ways to do that through activities, healthy activities, contributing, maybe volunteering, comparisons. And this is saying, well, it could be worse. Comparing myself to other people, not in, I'm better than you kind of way, but just saying it could be worse. My situation isn't as bad as it could be. Sometimes that can be helpful. Opposite emotion action can be beneficial. So instead of, if you're feeling really down, maybe, watching a sad movie isn't the best. Maybe a comedy would be more helpful. Pushing away other thoughts, other sensations. These are some other distraction skills that can be used. So it could be specific thoughts, specific other sensations. Again, all things that would be helpful, healthy activities. So interpersonal effectiveness, this is an area that we're discussing because this is part of the provider and patient relationship, and we have an acronym for it in DBT, and it can help you get what you want. So it's something that you could use with the patient, but also teach them how to use to be more effective, and who doesn't want to get what they want? So this is the way to walk through that in a helpful way. So describing the situation, explaining what you're reacting to, sticking to the facts in a succinct way, expressing opinions and feelings, again, very briefly, and giving a rationale, and then asserting by asking for what you want or saying no clearly, depending on what the situation is. Reinforcing or rewarding ahead of time, helping a person feel good ahead of time for doing or accepting what they want. So even just something, thank you so much for taking the time to talk to me today. This is an important issue. The thing I am having difficulty with is blah. Staying mindful, so focusing on the objectives. I'm sure we've all had the experience where you start talking about one thing and then you end up talking about lots of other things and you forget what you were talking about in the first place. So trying to stay focused on the objectives. Sometimes this is a broken record technique, so if you have to repeat yourself, or another skill is ignoring. So if the person is trying to intentionally divert you, or if there are any threats or attacks, trying to stay mindful and focused on your objectives. Again, if this is getting to the point you're feeling really uncomfortable or unsafe, then taking a break. Appearing confident is important as well. So being effective and using a confident voice, good eye contact, not stammering or retreating, but feeling like you can ask for what you want and that you can be confident in that approach. And negotiating. So being willing to give to get. It doesn't have to be all my way or all your way. It's not black or white. So there is a gray area here. And that can be very challenging for patients with borderline personality disorder because it tends to be that black and white area, and the gray gets lost a lot of the time. So the negotiation is a good place to focus. And then if that person is getting stuck, sometimes turning the tables can be helpful. So maybe you just say, I'm out of ideas here. Not able to say yes, but just seem to really want me to. What can we do? What do you suggest? So just turning that back over to them. So say, for example, your patient is demanding a medication that you don't think is clinically indicated, and they're starting to get pushy, you're starting to feel really uncomfortable. How could you actually use this skill? So you could say something like, thank you for coming in today. I understand you're here requesting whatever medication, we'll say Xanax. I'll not be able to prescribe that medication at this time because it's not medically indicated. We can discuss other ways of managing stress besides medications. How would you like to proceed? So this is a way that you could succinctly use a lot of those skills all at once. And I think that as we walk through these, sometimes it can seem like these are overwhelming or they'd be very time consuming. But I think that once you think about it a little bit and maybe get a little more comfortable with them, you could see how you could use them pretty quickly and easily. Emotional regulation and how to let go of emotional suffering. This is another skill within DBT. So one of the things that can be beneficial is just observing that emotion. So noting that it's there, stepping back and getting unstuck from it. So even just recognizing, wow, I'm feeling really stressed right now, or I'm feeling really frustrated right now, and this isn't who I am, or this isn't all that I am. So just taking a step back and trying to recognize where that's coming from, and maybe even modeling that for the patient or helping them to recognize and put a label to that emotion. Sometimes you can help them to understand how to experience that emotion. So as a wave, it'll come and it'll go. Emotions are always coming through us. And so there's no emotions going to stay permanently. So trying to kind of weather that storm, not blocking or suppressing it or trying to get rid of it or pushing it away. The opposite too, not trying to hold on to something or keeping it or trying to amplify it if it's not necessarily the most beneficial thing. So I think this is kind of like, it's like you're really happy to be at a birthday party and you just want to keep having that emotion, and because the birthday party's ending, you start feeling bummed because you're not as happy anymore. So it's like recognizing, okay, I can be happy when I'm happy, and some days are better than others. These are probably all things that a lot of people know intuitively, but putting this structure and these words to it and communicating that you understand that can enhance your relationship with the people you're working with. Also helping patients to recognize that they are not their emotion. They don't have to necessarily act on it. Just because you feel something doesn't mean you have to necessarily do anything about it. And remembering times when you feel different. So I think sometimes patients have said to me that, they're just so angry all the time. They almost feel like they're the embodiment of anger. But helping them recognize that this isn't 100% of the time. And so that can just be a way in. And practicing accepting emotions. So we have emotions for a reason. It's telling us about ourselves and about the environment. So trying not to judge, trying to take that accepting stance and practice willingness. And then again, that opposite emotion action is coming into play. So if you're having a really hard time, see if there's something else that somebody can do to bring about a different emotion, and then come back to the situation that was causing you so much difficulty in the first place and see if you can do something about it that's going to be healthier or keep you feeling better about yourself, something that's more in keeping with your goals, your values. So this could seem like a lot, and this is just kind of the tip of the iceberg when it comes to DBT. But generally, I would say that with some of this upfront work, it can save you from more difficulties later. And so it's kind of that short-term pain for long-term gain. You may find that you're investing a lot of energy up front, and that ultimately your patients are going to be benefiting as with your team. Team approaches are great. Using the expertise of another trained professional is wonderful. Even sometimes, doing those co-consultations where if you're lucky, you can have a couple of different people in the meeting at the same time with you in the patient. Maybe a behavioral health provider and a PCP, or maybe it's, an MA and a PCP, a couple of different people in there, or maybe even a colleague. You've both worked with the patient because of scheduling issues, and maybe you decide to come together to try to come up with a team approach. It can ultimately save you lots of time. Patients can feel really supported, providers can feel supported, and ultimately everybody's just kind of feeling better. Okay, so here are some references. This is not an exhaustive list, just a few. So we went through that actually quicker than I thought I would. I think that's my East Coast heritage and fast talking getting in my way. But thank you for listening and joining us for the webinar. I'm happy to take any questions, and hopefully I can answer them for you.
Thank you so much, Dr. Brown-Levy. And so we have time for questions. And like I had mentioned in the beginning, if you'd like to submit the questions, you can either enter into that little questions box at the bottom of your GoToWebinar control panel by typing them in, and I will read them out loud, or you can raise your hand using the little icon on the side of the control panel, and I will unmute you. Right, so we have a question. How do you convince organizations to pay for this kind of training for their primary care staff?
Wow, that's a good question. Well, I think that if you're looking, what I would think about is if you're thinking about high level accounting issues, and if you are potentially getting penalized for patients, that are high utilizers, and you can identify that this type of intervention would be beneficial, then I think that that could be one way. So looking at high level accounting, and if you're able to pull up, for example, a complex patient registry, and you're seeing that some of these behaviors are consistent with those patients, then it could be this type of training would be helpful. I think also these are skills that, again, they cross lots of different diagnoses. So we're talking about borderline today, but it certainly would play a role with chronic pain, as well as even just something as simple as self-management support. So I think that my initial thought would be looking at the level of accounting and seeing if there's a way that you might be able to do some cost offset.
Thank you. Our next question are, what are some good screening questions to help clarify differential diagnosis between bipolar and borderline personality disorder in primary care?
Well, there are some screening questions for bipolar. A lot of clinics use the MDQ, and before even using the MDQ, the mood disorder questionnaire, they may even have a 1 or 2 question screener before that. Generally, what we do is this is a little bit of a tricky area. So this is where a lot of times our behavioral health people come in and help us with diagnostic clarification. If you don't have that, but you can work with a psychiatrist or do a referral, that could be helpful. If anybody has any training on the SCID, then you don't have to necessarily do the full SCID, but that is a way to use questions that are consistent with DSM, so that it's not just, I have a feeling that this person might meet criteria, but it's actually consistent with the diagnostic, the DSM-5.
So our next question is, how do you approach families, and what advice do you give them in coping with a family member who has borderline personality disorder?
I think it's wonderful when you can have families that are coming in. Unfortunately, a lot of times this isn't identified until adulthood, and we don't get a lot of families coming in. One of the approaches I've seen when you can identify that this is a problem in early adulthood, or is if we did a group actually with young adults and family members. And so one of the things that was helpful was teaching some of these skills to the family as a whole. So it's not just one person trying to learn skills and then integrate them, but getting the whole family's approach to, this is the conceptualization of what's happening here. This is why this person is feeling this way. These are some of the ways that behaviors may be manifesting. And here are some things that you might want to do as a family, sort of similar to negotiating that relationship with the provider and the patient. There might even be, a contract that a family decides to create on their own, saying, here are the things that are acceptable, here are the things that aren't acceptable, these are the skills that we're going to be working on, here are the consequences. And so having something that's very straightforward written down can be helpful to refer back to.
So it looks like we had a few folks who might have lost sound during the overview of the radical acceptance of emotions. Do you mind reviewing the last few items on that?
Sure, we can maybe go back. All right. Let's see where we were. Okay, so in terms of acceptance of the emotion, I think a lot of times when we're experiencing negative emotions, the first instinct is to try to make that emotion go away as quickly as possible. And so it can be really difficult to ride out the storm. And that's where a lot of the really impulsive behaviors come into play. So that's where you might see somebody who just wants a release and might engage in self-harm or is feeling really down and may engage in promiscuous behaviors. So helping patients to regulate their emotions can be really helpful in reducing some of that high-risk behavior. So some of the things is helping them, and there is actually a very long section in the DBT workbook that helps patients to identify emotions. So the first thing is observing the emotions, so helping them even just put a label to it. And this can be really helpful, and you can even do it in the visit. So especially if somebody's at a heightened emotion, you can say, what's happening here? What is this emotion that you're feeling? Could you put a label to it? And help them just ride out the storm. Even if it's just for a few minutes, it's like, wow, you could have, what are some other ways that you've done this in your life? When you feel this and you're at home, what are some things that you might do? And you're not doing that right now. So what is it exactly right now that's preventing you from doing that? How are you able to regulate this emotion? How are you able to notice it and not behave in that way that's going to get you into trouble? So helping them to notice it, step back from it, getting unstuck, and saying, okay, this is, I felt differently. I can almost observe this as if I was floating above myself and looking down. So instead of feeling like you are the embodiment of that emotion, just putting a label on it, getting a little distance on it. Helping them say, there are some ACT metaphors that are really helpful here. You could even Google them on YouTube. There are some really nice videos that overlay with these concepts nicely, where you can experience that emotion. You can notice it coming, notice it going, not necessarily feel like you have to push it away or that you can't stand it, but recognizing that it comes and it goes. It's real, it's there, and what are some skills that you can use in the interim to keep you healthy and keep you moving forward. So the non-judgmental stance is really helpful here. Practicing accepting that emotion regardless of what it is. Not saying that it's good or it's bad, but that emotions are just part of our makeup as animals. We have them for a reason, and evolutionarily speaking, they're helpful. It's kind of part of what helps us run from lions. You feel that anxiety and that fear and you run. It's that fight or flight. So it's an adaptive thing, but it can also be maladaptive. So helping them to understand that emotions are always there, they're always present. It's just what are the skills that they can put in place to help them manage it in the moment, so they're not going to do something that they would later regret. And that's where you might bring in breathing or distress tolerance, some distraction skills, things like that. I hope that answered the question.
Great, thank you. And so we'll stay on for another minute or two to see if any other questions come through. Thank you, everyone, for joining us today, and thank you so much, Dr. Brown-Levy, for this fantastic presentation. Have a good day.